We're going to start with the main symptoms in the respiratory system. There are three, and they're very easy to remember, and I think you all know them anyway. There's dyspnea, there is chest pain, and then there is cough. And of course, with cough you have hemoptysis. So in some ways, the respiratory system is one of the easier systems to remember from the point of view of symptoms. Cough and chest pain. So what are the particularities or the things to remember about dyspnea and the lungs? Well, you have to grade it, just as in the cardiovascular system. And grading means what brings on the dyspnea. Does it occur at rest? Does it come on exercise? And then what type of exercise does it come on? In addition, with the respiratory system, you have to think of diseases that, like asthma, where the dyspnea is intermittent, paroxysmal, comes and goes. And like all symptoms, they all have what's called a time course. That's very important. Their onset, their duration, and the details of that. So the next main symptom in the respiratory system is pain. So what is peculiar to the respiratory system? Well, two things. One, pain from the lungs usually arises laterally, i.e. from the sides where the lungs are, not in the midline. And the second thing is the pain is what's called pleuritic. Pleuritic means that it is aggravated or related to breathing or to the pleura. And of course, that means then that the red flag or the thing to remember with chest pain coming from the lungs is that it can be aggravated by breathing, by coughing, and even by movement. Now, in addition to that, you have to go through what I call the 9 or 10 points about pain, as you would for pain anywhere in the body. Its severity, its time course, aggravating, relieving factors, associated factors, previous history. So it's very important to document those. The last main symptom that we concentrate on is cough. And cough is either productive or non-productive. And if it's productive, you always have to say what's in it. And in summary, you know this, but the cough can be what's called mucoid or purulent or contain blood. And if it's blood, then that's called hemoptysis. And again, you have to go through what's called the history of the cough, i.e. hemoptysis. What brings it on? Is it there all the time? Does it only come on at night? In particularly, its associated symptoms. For example, cough in the respiratory system is often linked to the other two main symptoms that we mentioned, pain and shortness of breath. And so in summary then, the respiratory system is relatively easy from the point of view of symptoms. You just have to remember three: dyspnea, cough, and chest pain. But the important point to remember is that you have to go through these symptoms in detail. That's called the history of the presenting complaint. So when you're finished with the symptoms of the respiratory system, then you go on to the usual routine for history taking. That is past history, family history, social history, drug history, allergies, and systems review. And if it's a female, you've got to go through obstetrical and gynecological history. So what is particular for the past medical history in the respiratory system? Well, logically, any diseases that will affect the lungs. The first one is tuberculosis, and the second one in our environment is HIV. And after that, it would be a history of pneumonia, a history of bronchitis, and after that, you could consider the possibility of what we call exposure diseases, i.e. occupational diseases where the person may be exposed to something at work, like mining. These are just examples that you have to think of when you think of the past medical history. In all past medical histories, you ask about the person's previous medical history. Number one, do they have an illness? Number two, were they ever hospitalized? And number three, did they ever have an operation? Or any specific risk factor that would inform you about the presented complaint. Family history. Well, the family history is in our environment is important from the point of view of TB exposure within the family, because it's often the mechanism of transmission, particularly with older person transmitting to a younger non-immune host. HIV is a risk factor for TB, even though it is not transmitted by coughing. And in addition then, you've got the common family history of allergies, asthma, eczema, and also what we call passive exposure to smoking, which could indirectly injure somebody's lung. That is known nowadays. As regards social history, I think you're very familiar with social history. Very simply, it's the patient's occupation and main social habits. And the social habits inevitably involve what we call smoking and drinking. Now, the quantitation of the exposure to those two are very much fashionable in industry nowadays. So we always like to know the number of pack years that a patient has been smoking for. If I'm smoking for 20 cigarettes a day for 5 years, then my exposure is 5 multiplied by 1 pack year, so that's 5 pack years. If I did it for 30 years, it would be 30 pack years. If I smoked 2 packets a day, it would be 5 by 2, which would be 10 pack years, or 30 by 2 would be 60 pack years. Alcohol is the same. You've got to early decide the type of alcohol, because one is higher in alcohol content than the other, and then the quantity. And the occupational exposure is becoming more and more important in our environment because of mining and because of exposures. Factories and even farming and animal husbandry with the zoonosis are now topical. Drug history, you have to document the number of drugs, the actual, their dosage, and the frequency they've been taking. Obviously allergies and systems review is automatic, and then finally obstetrical and gynecological history. I think we can stop there. Thank you. So now we're going to proceed with the examination of the respiratory system. And Godwin, a final year medical student, has volunteered to be examined today, and thank you very much for that. We've done Godwin's vital signs: his blood pressure, his pulse, his temperature, and his respiratory rate, and they're all normal. And we'll start now with the examination of the respiratory system itself. If you note that he's undressed to his waist and he's sitting upright in a chair, were he a patient, you would put him at 45 degrees. And that's very important to emphasize. And then you begin your inspection from the side and you look for any abnormalities. And then when you finish your inspection from the side, you always go to the front or to the end of the bed and do the inspection from there. Starting with his general appearance, this is very important for medical students and doctors to learn. From the general appearance, we often can see whether the patient is well or unwell, sick or not sick. And if you were unwell, you'd be looking for signs of wasting, anemia, or some sort of distress, pain. So Godwin is a healthy final year medical student, so today is about the demonstration of a normal examination. You're finished now with general appearance, and the next part of the respiratory examination involves what we call the chest, or the lungs proper, as I call it. But students have to remember that there are peripheral bits that may or may not be forgotten. And most doctors examine the peripheral bits first and then go on to the examination of the chest proper next. The peripheral bits, in this case, would involve the hands and would involve the head, face, neck, and even sometimes the legs, when the legs are swollen, related to a lung problem. So Godwin, looking as it were at the peripheral parts, the first part to look at is the hands. Can you hold your hands up like that? And immediately you see that there's no clubbing. I don't see any cyanosis or anemia. in the fingernails, please turn your hands over, looking for pallor, and there's no obvious pallor. And can you put your hands out like that? Hold your hands back, and I don't see any flap or asterixis, which would indicate respiratory failure. Thank you. The next part of the examination, we feel the pulse, and in this case, we only document the rate or any obvious abnormality in volume. The reason is we're looking for some abnormality in the pulse that would reflect disease in the respiratory system, and the condition that would indicate that would be pulsus paradoxus that we sometimes see in acute asthma. Moving on then to the head, face, and neck. You look at the patient's conjunctiva. Godwin, can you look up for me? And here we demonstrate the conjunctiva. There's no anemia, and there's no signs of polycythemia, or no other obvious abnormality like jaundice, which may or may not be relevant. Coming down to the mouth, you look at the lips for cyanosis, but in that case it would be peripheral cyanosis, and it's necessary now to check for central cyanosis. So please open your mouth, put your tongue out, and you look at the tongue and see if it is blue. And finally, you would look at the palate to see if there were any abnormality there that might suggest another disease, for example, Kaposi sarcoma or Monilia, that might indicate immunosuppression. I mentioned that we should always check the legs in conditions that might involve the legs, and that would be unusual. Now, coming on to the examination of the chest proper. The format for that is always the same. It begins with inspection, palpation, and then followed by percussion and auscultation. Now this is when we inspect, as it were, formally. I reminded you at the start of the examination, you inspect from the side and then from the front. And what are we looking for? Well, you're looking for any obvious abnormality. And please remember, the teaching says that you look at what we call the chest wall for any deformity. For example, pectus carinatus, chicken chest, or pectus excavatum, or maybe a scoliosis, which you've seen. The next thing is to look at his breathing pattern, and here you're looking for a respiratory rate and any abnormality in breathing. For example, if the patient has difficulty in breathing, you look at the pattern of respiration, because as you know, there are two types of breathing. There's abdominal and respiratory. Females tend to do more respiratory and males more abdominal. You document the pattern and the rate. The normal rate is between 14 and 18. Anything greater than 18 is called tachypnea. Then you look for what we call his breathing, and if there's any respiratory distress. So what are the signs of distress that you look for? Well, using the accessory muscles of respiration, and we can start at the top and work down. They are the ali nasi, the sternomastoids, the scalenes, the intercostals, and the subcostals. And even another sign is the tracheal tub, where the trachea goes down every time the patient takes a deep breath. So there are about 6 groups of respiratory muscles, and you should look to see if they are in action. That would imply that the patient's in respiratory distress. Well, after locating the trachea and the apex beat, the next and probably most important part of the examination of the chest is to check for expansion. And the way we check for expansion is as follows. Godwin, I'm just going to put my hands on your chest. Good man. You try and cover, you place the flat of your hands on both sides with your fingers widely separated and adherent to the chest wall. You approximate your thumbs in the midline, but slightly off not actually lying on the chest wall. And then, Godwin, I'd like you to breathe in and out. And here you see both thumbs separating, but only by 1 centimeter. Now, Godwin, I'd like you to take a very deep breath, big deep breath. And here you see my fingers separating by up to about 4 or 5 centimeters. You see? That is normal. And both sides move. I can do the same in the axilla. Just separate you, just lie back. Now, again, now take a deep breath. And here you see the same thing happening, both sides moving. And then I repeat the maneuver behind in exactly the same way. Now I'm checking for the lower lobes. Godwin, take a big deep breath. And the fingers separate after a deep breath by somewhere between 4 and 5 centimeters. That's normal. Now, I can confirm that chest expansion is normal by measuring expansion at the nipple line. Godwin, if you could sit forward for me. And then and just here. And that's, so his normal chest expansion in the neutral position is there. Now what I'd like you to do is to take a very deep breath for me. Take a deep breath in, and that's his 5.5 centimeters. That's normal chest expansion. Examining for chest expansion is very important, particularly where there is what we call emphysema or widespread lung disease. Expansion is diminished, and you may miss it unless you check for it. That completes the examination of palpation. Now the next part of the examination is percussion. And percussion is done from the front, is done from the sides and from the back. We begin in the front by percussing the clavicles, and then in what's called the midclavicular line, comparing right with left. And if you listen, 2 taps on the clavicle reveal the same note on both sides. And then, just going below the clavicle in the second interspace, you percuss. You place your, in this case I'm right-handed, you place your left hand firmly against the chest wall, and then you use the middle finger, the distal phalanx of the middle finger, and you tap twice in the following manner. If you notice, nearly all the movement is either coming from the wrist or the fingers. It's not coming from the hand. Like this. And you compare to the other side. Only tap twice. And then that's sufficient. I've tapped 3 times on the right. In the axilla, you repeat the same maneuver. Hold your hands up in the air, please. That's sufficient. And then twice in the axilla is sufficient. Posteriorly, it's important to remember the root of percussion. It begins in the apex, it comes down medially to avoid the medial border of the scapula, and then fans out as you go down, right down to the 11th rib posteriorly, which is the lower border of the pleura at the back. Now I'll demonstrate that to you. You can listen. You tap high up. Remember, the apex of the lung is actually quite high up. So you can tap, that's lung. And then go down medial to the border of the scapula in a C-shaped direction. Down, down. I'm already just below the lungs. I've tapped at the apex, and I've tapped approximately 5 times, comparing right with left. If you come across an area of dullness or resonance, it's important to map out the area. What do I mean by mapping out the area? Well, let's imagine that his right posterior lobe was dull, and if you listen to the percussion note, and then we tap out that area of dullness, listen, and measure it. So he's got an area of dullness approximately 12 centimeters in the right lower lobe. Of course, he hasn't got that, but in theory, if he were a patient with dullness, that's the way we would map it out. And then the implications of that follow. Dullness usually associated with consolidation or pleural effusion or fibrosis. Resonance, on the other hand, is associated with pneumothorax or emphysema, and of course, stony dull is associated with pleural effusion. That completes percussion. Now, so the final part of the examination of the chest is auscultation, and to medical students, that is often the most difficult. And the reason is that it implies that you know what is normal and you can pick up what is abnormal. Therefore, you have to know what is normal. Even before you do that, you have to learn some techniques. One is, which part of the stethoscope do we use to examine the chest? Now, I always use the diaphragm of the chest, the diaphragm of the stethoscope, this part. The other part is called the bell. And all my 43 years in practice, I've been using the diaphragm. Some textbooks actually recommend the bell for examining the lungs, but most will suggest the diaphragm. We may use the bell for low-frequency sounds. Sometimes you hear those with fibrosis, with obstruction of the airways. And in very thin persons, you may get difficulty putting a flat diaphragm on the chest wall, and the bell is more useful. But beyond that, we use the diaphragm. Please remember that you have to hear the sounds. So that means you have to tell the patient sometimes to breathe in a bit more deeply and a little bit more rapidly than usual. Sometimes you hear the doctor saying, please take a deep breath, in and out, in and out. If you notice that he is listening both to inspiration and to expiration, that's important. We listen to the two separately. And when we're auscultating, we're always comparing right with left, just with percussion and with palpation. Comparing right with left. In principle, if you want to know where to listen, if you listen at the sites that you percuss at, that is sufficient. If you think about it, you percuss at approximately 3 sites in front, 2 in the axilla, and 6 posteriorly, comparing right with left. Now, before we move on to auscultation, we should say a little word about normal breath sounds and abnormal breath sounds. Normal breath sounds are either bronchial or vesicular. Bronchial is heard over the trachea, the larynx, the trachea, and its bifurcation. Trachea bifurcates roughly at the sternal angle into right and left main stem bronchus. Posteriorly, it does it around the fourth thoracic vertebrae, a bit lower, technically. That means you can hear breathing through the trachea and its main stem bronchi over there. That is bronchial breathing. What is bronchial breathing? Well, it's a continuous breath sound where inspiration is the same length as expiration, but there's a gap between the two, and inspiration may be slightly louder. Maybe slightly louder sometimes. So, if we hear bronchial breathing over any of those areas, that is normal. The rest of auscultation, the lung field, is vesicular. Vesicular is what happens at your air spaces, and they are continuously expanding and contracting. Therefore, the sound is a continuous sound. It's a different resonance and a different quality than bronchial breathing. It's a continuous sound with no break between the two, and with inspiration slightly louder and longer than expiration. That is the normal vesicular breathing, and this is what you hear over the lung fields. Therefore, if you hear either bronchial breathing or vesicular breathing in a place where it shouldn't be, that is abnormal. In the same way, if they are not present in a place where they should be, that is abnormal. That's the first statement about abnormal breath sounds. The second statement is additional breath sounds. If you hear a sound that is additional to those two, then it is abnormal. And then there are really only two types. They're called interrupted or continuous. Interrupted is a crepitation or a crackle. And they can be quantified as what we call, they can be fine, they can be medium or coarse. So before we complete the auscultatory examination of the respiratory system, we should examine for what's called vocal resonance. And you remember we examined for tactile fremitus when we did palpation. We do the same for vocal resonance. Usually we do vocal resonance when we suspect there is an abnormality. For example, you found an area of dullness on one part of the chest, or you found an area of hyperresonance, say, and you'd like to check to see if resonance is impaired. And the way we do that is we do exactly the same as we did for palpation, except we listen. So Godwin, I'd like you to say 99, and then I will listen into your chest. Say 99.
99, 99, 99, 99.
Sit forward, please.
99, 99, 99, 99, 99, 99.
And of course his vocal resonance is the same on both sides. I'd like to emphasize that you have to press the diaphragm firmly against the chest wall for resonance. You do not want anything between your diaphragm and the chest wall that would interfere with the sound. It's a very pure sound, and you're comparing like with like. Please remember, as students, your best friend in examination of the respiratory system is the other side of the chest. In other words, in many cases, one side is abnormal and the other side is normal. So please examine and compare and contrast right with left. Remember that your best friend is the other side of the chest wall, which is often or usually normal, and we're using both sides for comparison. And that helps you define the abnormality. That completes the examination of the respiratory system. Thank you. Nane.